Good afternoon, everyone. This is the 2021-2025 Cancer Plan webinar series, and our topic today is colorectal cancer. Thank you for everyone who's joining us today. We have an exciting presentation with three amazing speakers lined up. My name is Shantae Davis Patterson, and I'm the Program Director for California's Comprehensive Cancer Control Program, we administer, the California Dialogue on Cancer, or CDOC. Next slide, please. So just a little housekeeping before we get started. All participants have been muted. Please ask questions in the chat box. These will be addressed at the end of the webinar. This webinar is being recorded, and we will be disseminating it after the webinar, probably next week sometime. And for our webinar objectives, we'd like to, if we can go back to the previous slide, please.
Sorry.
And I also wanted to mention that we do have an evaluation for this webinar. So I will drop the the evaluation link in the chat. And if you can please help us out by completing that evaluation, that would be great. The webinar objectives today, we're going to familiarize participants with the progress to date for controlling colorectal cancers as it relates to the cancer plan. We're going to educate participants on current efforts at the state and national level to improve access to care and outcomes, beginning with screening and through the care continuum. We're going to identify opportunities to work together going forward that integrate the California Cancer Plan goals and objectives to reduce late-stage disease and fewer deaths from this largely preventable cancer. Next slide, please. And I just wanted to begin just talking about a little bit about implementation for our 2021-2025 cancer plan. As most CDOC members know, the cancer plan does remain in the state approval process. However, given those unexpected delays, we have been given the green light to begin dissemination of content as well as implementation. The initial dissemination of our plan content is happening through this webinar series that we're putting on, and also through the work of our work groups and special projects of CDOC. And then the implementation of projects aligned with cancer plan objectives and strategies has been initiated through the Comp Cancer program. And you can get involved with CDOC and implementation efforts. Just send an inquiry to our Gmail at cdocshare@gmail.com, or you can visit our website at cdoconline.net. Please keep in mind that we're still building this website out, so there is limited information, but you are able to join. But again, you can always send an inquiry to cdocshare@gmail to find out more information. All right. Next slide, please. And for this webinar series, as I mentioned, we will be having future webinar dates and topics that we're planning now. We're hoping to present health equity for April, but stay tuned. We'll send out more information on that. Next slide. All right, and our speakers today, I'm happy to introduce Dr. Laura Getz. She's going to be taking a look back at all of the colorectal cancer objectives in our cancer plan, beginning with our 2011-2015 cancer plan. Dr. Getz is the director for cancer prevention and early detection at TGen, or Translational Genomics Incorporated, an affiliate of City of Hope. She's also a CDOC colorectal cancer working group member, as well as a member of the California Colorectal Cancer Coalition, or C4. Our next member, which many of you know because he is a past chair of CDOC, is Dr. Stonewall Anderson, and most of us call him Stony. He is going to go over our current colorectal cancer efforts. And Dr. Anderson is the president of C4. He's also the co-chair of our CDOC colorectal cancer work group and volunteers at UCSD as a clinical professor. And last, we have Dr. Margaret Hitchcock, who will talk about the pathway forward with progressing these efforts and collaboration opportunities. Dr. Hitchcock is the vice president of C4 and also another co-chair of our colorectal cancer working group. So without further ado, I'm gonna turn this over to our first speaker, Dr. Getz.
Thank you, Shantae. And if we can advance the next slide. I'm going to start out with an overview of some recent colorectal cancer facts and figures from California. This is a compilation slide from the California Cancer Registry fact sheet from last year. And if you look at the far left hand, we'll start with that. This year, we expect over 15,000 people to be diagnosed with colon cancer and over 5,000 to actually die from colorectal cancer. So both of those figures keep colorectal cancer in the number 3 position in terms of incidence and mortality if you look at males and females. So males, it's after prostate and lung, and in females, it's after breast and lung. Interestingly, if you look at combined statistics for mortality, colorectal cancer is still the second leading cause of cancer mortality when you combine males and females. And that last item on that left column is telling us again, obviously, that African Americans continue to bear the highest burden for both incidence and mortality from this disease. That second column shows the 5-year cancer survivor rate. And localized and regional 5-year survival rate is still excellent, so that's good. But distant, that third column down, the distant 5-year survival rate is still abysmal. So our overall 5-year survival rate for all stages continues to be less than 70%. So we still have a lot of work to do, obviously, in that area. The good news is in that third column, our incidence and mortality trends continue to go in the right direction. So since 1988, we've decreased the incidence and mortality significantly. 46% mortality rate decrease is something we should be all very proud of. And that last column, of course, we all know the benefits of screening. We can completely prevent colorectal cancer. We can actually detect it in earlier stages. And also, we are now aware that implementing low-cost screening tests can actually prevent nearly half of all the colorectal cancer cases that are currently diagnosed at a late stage. So this is, important information to know as we think about what types of screening tests are best. You can go ahead. So I'll start with the 2011-2015 plan. This actually had 3 objectives that were under the early detection and screening topic. So the first objective was to increase colorectal cancer screening rates among people over 50 using the most up-to-date United States Preventive Services Task Force guidelines. The second objective was to decrease late-stage diagnosis of colorectal cancer, and late stage included both the regional and distant stages. And the third objective was a disparity objective to decrease late-stage diagnosis, specifically in African Americans and Asian Pacific Islanders. That cancer plan also had a cancer site-specific objective that was to reduce the overall colorectal cancer mortality rate. Next slide. The 2016-2020 plan was very similar, and it had the early detection and screening category, and it actually gave some specific measurable outcomes for those objectives. So the objective 1 was still for screening rates to increase them in all Californians over 50, but it was actually to increase that number by 24%. And then the second objective was to decrease the late stage diagnosis also, but to decrease it by 10% specifically. And the third objective was rolled into the cancer-related health disparities objectives, which was to reduce the proportion of late-stage diagnosis for several cancers, and specifically targeting that to California's racial and ethnic minority populations. So this next slide is a compilation of the data that we've calculated for those 2 cancer plans. And I'm not going to go over this line by line in the interest of time, but I'll just give you an overview. So the first column is obviously a list of the objectives. The second column looks at which cancer plan dates we're referring to. The third column gives us the baseline data that we used to develop those objectives, and the reference year for those statistics are in parentheses there. The next column there is the target that we had determined for our objective, and the next column is the progress that we had made or not made, as the case may be, and the reference year again for that latest year for statistical information. And the last column shows the source for the data. So we've used different sources for some of these, which makes it a little bit hard to compare. We're not always comparing apples to apples in this situation. For those of you who don't know, CHIS is the California Health Interview Survey, CHIS, BRFSS is the Behavioral Risk Factor Surveillance System, and CCR is the California Cancer Registry. So if we look at that progress column, in general, the numbers that are in black are all going in the right direction. So that's the good news. All the latest information shows that we're going in the right direction for most of those, but there are two that are in red, which are going in the wrong direction. So if you look at objective 2, the data from 2016, we wanted to go from a baseline of 45% for the late stage diagnosis to a target of 41%. But for that year, unfortunately, we went up to 48%, which was actually worse than even in 2012. And if you go down to objective 3, the other one that's in red is for the late stage diagnosis in American Indians and Alaska Natives. And instead of decreasing from 55% to 50%, we actually increased to 56%. The good news in the Hispanics was that we went down, we met our goal and exceeded it. So we went from 56% late stage diagnosis to 49% in 2018, sorry. Obviously, the pandemic is going to affect these numbers, so it'll be interesting to see what we have going forward. But I think overall, the message is that we have been going in the right direction for most of these. We still have a long way to go to actually meet our targets, and we have several areas where we're going in the wrong direction. So we have our work cut out for us in this regard. And with that, I will hand it over to Dr. Anderson.
Good morning or good noon. Next slide, please. In our latest cancer plan, we've really got 3 objectives. And the first one was our disparities objective, and I'll go over each of these objectives individually over the next few slides. And it was decrease the rate of late stage, well, go back one slide, please.
Sorry.
Decrease the rate of late stage diagnosis of colorectal cancer among those covered by Medi-Cal and uninsured. And number 2 was continue to increase the colorectal cancer screening rate among all Californians to 80%, and 3, decrease late stage diagnosis among all Californians between the ages of 40 and 49 because of the increase in colorectal cancer screening or colorectal cancer incidence and mortality in this age group. All right, next slide, please. So we used late stage diagnosis as the best way to assess the problem and disparities in California related to colorectal cancer screening and mortality. And on our work group, we were surprised to discover there were only minor differences between the ethnic groups. And in California, the main difference was in Californians' access to medical insurance. The high late stage diagnosis in the uninsured was expected, but we were surprised to find that having Medi-Cal insurance was the same concerning colorectal cancer screening as measured by late stage diagnosis as the uninsured. This really wasn't a total surprise because the California Medicaid screening rate is really unknown. It was last measured using claims data in 2012 and was only 20%. It's certainly no higher than the HRSA measured California's federally qualified health center screening rate of 46%. And that's certainly lower than California's overall screening rate of 72%. And for California's over age 65, our screening rate is 82%. Because of the late stage diagnosis equivalency with uninsured, the most likely Medi-Cal screening rate is 34%. At this point, the providers and clinics that care for our Medi-Cal insured patients do not have a partner in their health plans to help them screen their patients for colorectal cancer, as I did in Kaiser Permanente. And we started working on our colorectal cancer screening rate in 2016. And we were close to getting Medi-Cal to add colorectal cancer screening to their required quality measures. And in 2019, it was on the agenda to be actually added to the Medi-Cal quality measures. But in 2019, Medi-Cal Managed Care decided to shift to the Medicaid adult quality measures. Unfortunately, the Medicaid quality core set does not include colorectal cancer screening. It includes breast cancer screening and cervical cancer screening, but does not include colorectal cancer screening, as does a commercial adult core set and the Medicare adult core set. So since 2019, we've been working to add colorectal cancer screening to the Medicaid quality set so that California would have it as one of their quality measures. And in collaboration with partners such as the National Association of Chronic Disease Directors and Levitt Partners and the National Colorectal Cancer Roundtable, we've made a great deal of progress in adding colorectal cancer screening to the CMS adult core set. And we actually got one of the members of the voting group on the group Mathematica, who decides what measures are added this year to be added next year. And we had the member of that voting group from the American Academy of Family Physicians recommend it. And we also had the member of that group from the Joint Commission recommend it. And on April 8th, we will find out if it is going to be one of the new measures to be considered this year for 2022 adoption. And if it is in May of 2021, this year, between the 6th and the 8th, there are 3 meetings that discuss the new measures, and hopefully it will be voted on and adopted. It was last voted on to be adopted in 2019. It got 57% of the vote, but it requires 66%. So we're very hopeful that first it'll be considered for adoption this year, and second, that it will be voted on and it'll be adopted, and it would be adopted in 2022. It's interesting, we started this because Jim Schultz, who's the medical director of neighborhood healthcare in San Diego, was very jealous of what I had in San Diego by working with a Kaiser health plan to increase our screening rate. And this was reported by T.R. Levine in 2018. And what he showed is that they were able to increase their screening rate almost 40 percentage points and had a 50% decrease in colorectal cancer mortality with increasing their screening rate. And I was part of this effort in Southern California, and the health plan helped, all the clinics and all the hospitals helped. And we really did a fit outreach, and we're able to have this massive increase in our colorectal cancer screening. And that could happen in our Medi-Cal insured population. So next slide, please. Now, this objective to increase colorectal cancer screening is one that we've had in all of our cancer plans since we first started back in 2011. And we want to get up to 80%. We're at almost 71% now, and we think we can get up to 80%. And one of the things that we're doing about this is the California Assembly Bill 342. And that removes cost sharing. We know if you remove financial barriers to colorectal cancer screening, more people get screened. And there's been numerous articles to show that the removing cost sharing does increase colorectal cancer screening. In the state, we can actually remove cost sharing in the commercially insured population. The commercially insured population is about 50% of our insured population, so it'll be a big move. So we're working with ACS CAN to have Assembly Bill 342, and it removes the co-payment that occurs after you get a fecal test, such as the FIT test or Cologuard, or a Flex Sig that finds a big polyp, or a virtual colonoscopy that finds a big polyp. And when you do one of these tests, the colonoscopy is required, but because of the wording in the U.S. Preventive Services Task Force, that colonoscopy can be coded as a diagnostic colonoscopy. And this would remove the cost sharing for that colonoscopy as part of the screening process. It also removes some people go in for a screening colonoscopy, and about 40% of the time they find a polyp. The colonoscopy then can be coded as a therapeutic colonoscopy, and people get surprise billing. And so this bill would remove all that cost sharing associated with the colorectal cancer screening continuum. And so far, it's been passed out of the Assembly Health Committee last week with unanimous support. There were no negative votes, and no one was negative against it. So that's where we are on Objective 2, and we'll continue to work with our federally qualified health centers to increase their colorectal cancer screening rate through our C4 grants program, which is awarded over $650,000 in grants. So we hope to continue to increase our screening rate in the state. And next slide, please. We do know that the U.S. Preventive Services Task Force has recommended that normal risk screening start at age 45. And the screening from age 45 to age 50 is recommended in the draft of the new U.S. Preventive Services guidelines as a grade B, so it would be covered. And so we hope that they continue to do this, and when they issue their new guidelines later this year, the screening age will drop to 45. The other problem is we know that early onset colon cancer is going up, and we know we've all heard the stories of people that have had rectal bleeding, but it's been attributed to hemorrhoids, and there's been no testing. So we want to make sure that we educate that any of the big symptoms of colorectal cancer require a full workup, regardless of the age. If someone's having rectal bleeding, you have to look at the colon. If someone has unexplained iron deficiency anemia, you have to look at the colon. We're also working with the American Cancer Society on evaluation of genetic risk. And this mainly starts with making sure that everyone gets a good family history, and those with a family history of multiple cancers, young onset, need to have genetic testing. So that's where we are on this group. Next slide, please. I think then I will introduce Dr. Margaret Hitchcock, who will be talking about the path forward and the implementation strategies. And we're glad to take questions at the end of this. Thank you so much.
Oops. Thank you. My goal today is to talk about the strategies that are linked into the 3 objectives that Dr. Anderson just reviewed, and some opportunities or suggestions about possible ways for you to get further involved. And as a reminder, Shantae included links at the very beginning on how to get a hold of people within CDOC if you're interested in getting involved further. So the objectives on future directions for Objective 1 link to improving strategies for completing screenings. So as Stoney mentioned earlier, it's a multi-step process, so that if a primary screen detects an abnormal result, you really need completion of that secondary screening colonoscopy in order for it to truly be considered a completed screen. So there's a lot of focus on how to make sure that that secondary colonoscopy is completed, in particular in resource limited scenarios such as federally qualified health centers, where they may struggle to get donated services for those colonoscopies. So some of the approaches are to get the health plans to incorporate, say, patient navigators, their community health workers, the promotorists, to emphasize the importance of completing the entire screening process. And then there's a variety of other proven strategies. And so on the right side of the screen, you can see some of the links to some of the programs. So I think the good percentage of people know that there's now a national initiative to promote 80% screening in every community. And this was building on a previous initiative of 80% by 2018. This side of the slide includes some resources through, so NCCRT is the National Colorectal Cancer Roundtable, and they have a variety of resources. And I want to reemphasize to everybody that that's a very robust set of resources, in particular for organizations that are trying to reboot their screening post or mid-pandemic. The National Cancer Institutes, they have evidence-based cancer control program ideas. This used to be called RTIPS, and so it's now been renamed. And then the community guide has a variety of resources on how to also improve your screening rates within communities. So this is some examples of implementing at the community level. So CDOC is currently in the process of contracts are pending for 2 grants focusing on colorectal cancer that each one will be funding at $85,000 through mid-2022. And so the first one is going to the City of Hope with focus on increasing FQHC staff effectiveness and patient adherence and improving public knowledge awareness of colorectal cancer screening and resources. And they're targeting the low socioeconomic status and racial ethnic populations, including African Americans, Latinos, and Asian Americans. And they're working with 5 federally qualified health centers in the LA County area. The Les Donac Clinic, and I apologize for mispronunciation. This project is aiming to implement colorectal cancer screening by developing instructional videos, reminder cards, and other education materials in Spanish and English, building upon currently available resources. So empowering the medical assistants as advocates for FIT testing and expanding their scope of practice to increase screening, engaging the community health educators to deliver comprehensive bilingual colorectal cancer screening education. And part of this, but not funded actually from this, directly from this grant, is to distribute 500 FIT tests to low-income uninsured patients who are due for screening. And then on the right side, the California Colorectal Cancer Coalition, we have a community grants program that we initiated in 2013 as a mechanism to basically try to help boost screening rates as one of our primary goals throughout the state. And so since 2013 and through 2020, we've released over $640,000 to 71 organizations. The majority of them are federally qualified health systems. And I say systems because most of the FQHCs have more than one clinic. So we're funding a much larger footprint than even the 71 organizations suggest. And if we look at what happened between 2013 and 2019, so the total FQHC population number of patients has increased from 3.4 million to 5.3 million patients. We have an estimate of about 670,000 patients were between the screening ages of 50 to 75. And I want to emphasize that that is an estimate because that data point is missing from the federal websites. But we're now at 1.045 million patients currently within that screening age, and that translates to about 19% of patients, and previous numbers that I've crunched said that that part is fairly stable. So I used that as we get a little further down in the next column, second column after this. But the screening rate in 2013 was sitting woefully at 33.6%. And our more recent data at 2019 is we're up to 46.2%. And so the number of patients screened in 2013, if you use that estimate of number of patients, was about 225,000 patients in 2013. And now we're closer to 500,000 patients in 2019. And so, you know, and this estimate of 258,324 is truly still an estimate, but it's probably a reasonable estimate. That translates to, you can see that the population being covered by FQHCs has expanded a lot. So that's 150% increase in patients during that interim of those years. But screening has increased by 215%. So the message is getting out, they're getting better. So the whole needle is shifting for California. I do want to mention that I'm planning to, so I manage the community grants program. And so I'm planning on holding a town hall in mid-August. I haven't looked at the calendar yet, but somewhere around August 15th to get a better sense from our past and current fundies and anybody else who wants to jump on the call about what resources might be really helpful for our next round of our request for application. So we tend to release these in fall, early fall, excuse me. And funding usually starts March 1st of the following year. So that would be March 1st, 2022. So stay tuned. We'll be releasing information through the CDOC website when we do that, with listserv when we do that. So moving on to objectives 2 and the future directions. It's implementing those evidence-based strategies according to NCCRT and the NCI EBCCP. The next one is requiring a California quality report card. And if you're curious about what that looks like, there's a link when Shantae shares the slides under the notes that includes a link to that reporting site. So all health plans would report their screening rates and it would be posted on that quality report. The next one is to develop a flu fit program in every clinic with colorectal cancer screening rates below 60%. I would add on, and I also mention it a little bit later, that people have had to become even a little bit more creative than just the flu fit. We have noticed through the person who developed the flu fit that some clinics are developing drive-through screening programs. Mailed flu fit has also become a very key thing in the midst of the pandemic. And then the next thing is develop clinic navigation to make sure that all abnormal stool tests have that follow-up colonoscopy. And from my experience managing the FQHCs through our community grants program is that that's a really key big item, is making sure that you document what happens to the patients after a positive colonoscopy. And then removing structural barriers to screening. Once again, this is really important in the pandemic. So structural barriers would include inconvenient clinic hours, lack of transportation, out-of-pocket costs. The mailed fit program isn't a barrier, but it's a way around the barriers. So it's important during the pandemic. And then improving screening during the pandemic. Here's a link that was recently released by ACS. So how to improve messaging for cancer screening in the midst of the pandemic. And then for objective 3, looking at future directions, family history, focusing on family history of colorectal cancer should be routinely asked. Encourage colorectal cancer survivors in all health plans to promote screening within their families. Used to be an old initiative with C. Everett Koop about using Thanksgiving to share your family history with your relatives. We obviously need different strategies in the midst of the pandemic. So screening for hereditary cancer syndromes in patients with colorectal cancer should be done. And at a minimum, review personal and family histories, evaluation of genetic risk, There's American Cancer Society recommendations for evaluation of risk. Patients' tumors. So if you've been diagnosed with colorectal cancer, your tumor should be analyzed for mismatch repair genes or for the presence of microsatellite instabilities. And there's a variety of ways to do that. And then these results should be reported to the cancer registry. And this should be a very strong focus. And, you know, if organizations focus on that, then maybe the cancer registry will start to have better data that they can then share with those of us who are collaborating with them. The final thing I wanted to focus on is to kind of put it on everybody's radar. So we are in the process of organizing the Western Colorectal Cancer Consortium Conference. We're a little bit in limbo because of the pandemic. This was a conference that was originally scheduled for last March. That's being rescheduled, hopefully, till October 14th and 15th. And so it will still, for those of you who heard about it before, it will continue to be at UC Davis Conference Center. We plan to open registration on July 1st. I plan to republish the agenda and speakers mid-April. We're pretty through confirmation of speakers or adding new ones. We've refocused and added in components of what to do in the midst of a pandemic, focusing, maybe highlighting even better racial disparities in healthcare delivery, and how to deal with what do you do with screening in the midst of pandemic, and how to make sure that patients get their follow-up colonoscopy and access to other than the next level of care after that. So I've included the website down there on the bottom. When you see the slides, so there's an example partial agenda. So the partial agenda on the right is really kind of setting the framework for the conference and some of our big overarching goals for what we want people to take away from the conference. So with that, I believe Shantae is ready for questions within the chat room.
Yes, and thank you to all of our speakers. I do see one question that we have in the chat. And I think this may go to Stony. Stony, can you
Sure.
Respond to this? Thank you.
Yeah, go ahead and get that my slide back if you can, Margaret. Go back to the one where we're talking about objective 2 in the current cancer plan, and that's AB 342.
Yep.
And here it is. AB 342. It removes cost sharing, and it's quite different than the federal one. The federal one only applied to Medicare, and the federal one, people in California in general were always a little upset that it mainly dealt with the polyp found during colonoscopy and the surprise billing in Medicare that occurred when that happened. And that surprise billing, I didn't mention this in my speaking, that surprise billing can be hundreds of dollars cost sharing for a colonoscopy. The average cost of a colonoscopy is around $1,800 and quite a bit, and your high deductible, high copay plans can be part of the cost sharing. So it's hundreds of dollars for a colonoscopy. We in the state can only legislate around commercial insurance. So to remove cost sharing in commercial insurance, which as I mentioned is 50% of the insured population of California, we wanted to get rid of all the cost sharing in the screening continuum. And there are many tests that are recommended grade A or B by the U.S. Preventive Services Task Force. Colonoscopy is one. So if you get a colonoscopy under this bill and you have commercial insurance and a polyp is found, there cannot be cost sharing. If you get a mailed out FIT or a mailed out Cologuard and it's positive, in other words, there's blood seen or DNA, tumor DNA seen, then the colonoscopy that is required to complete the screening sequence cannot have cost sharing. If you do a flex sig and find a large polyp that's going to require a colonoscopy, there cannot be cost sharing. And so that's what the Bill 342 would do. We passed a similar bill back in 2016, and Governor Brown was governor then, and he vetoed it because he thought it exceeded the federal mandate. Now, there's disagreement on this, but we are reasonably sure that the new U.S. Preventative Services Task Force will make it clear later this year that it's a screening continuum includes the colonoscopy after one of these positive screening tests that require colonoscopy. So we're less worried about that. But all we can do in the state is affect the commercial insurance market. In Medi-Cal or Medicaid, there is no cost sharing. And so we don't have to worry about that group. Their problem is, as we outlined in getting the quality measure added to the Medi-Cal quality goals, is that the health plans are not as interested in increasing colorectal cancer screening as are the ones they're having to report, such as breast cancer or cervical cancer screening. So that's the difference. Does that sound reasonable? Does anyone have any other questions about that? Because I'm glad to expand on this bill. This bill will be part of the ACS CAN's lobby day. We're going to try to make sure that all of the legislators know about it, and we're educating them as quickly as we can to make sure it's done. It costs very little. It costs maybe 0.004% of the healthcare budget. And if it increases FIT screening, there's a chance that it can actually put money back into the healthcare system, because FIT screening has been shown in a large mathematical modeling using the SysNet model to actually cost savings, not just cost effective. Colonoscopy is very cost effective, but FIT screening could actually put money back into the healthcare system because of the high cost of the chemotherapy for late stage diagnosis. So glad to answer any other questions. Or if I wasn't clear, I can clarify.
Yes, it looks like the person who asked the question did say thank you. So I think that does answer the question. Great. And I think what we'll do right now is just open up it to anyone else who wants to ask a question. If you didn't get a chance to put it in the chat, everyone is muted, but I believe you have the ability to take yourself off mute. So if there is someone who wants to ask a question, please do so. Take yourself off of mute. And if you can't, I will make sure that I do that. Do we have any questions?
This is great. We were very clear. And there's nothing wrong ever with ending a meeting early, but we do invite your questions.
Okay. Doesn't look like I see any coming in.
This is Lisa Russell. I don't have a question, but I have a comment. This was incredibly smooth and well-planned presentation. So thank you for all.
Oh, thank you, Lisa.
Thank you for that. Yes, we have, it was the speakers, all the speakers who prepared all this content in a short amount of time, I'll say as well.
I do have a request. Will these slides be available to us someplace?
Yes, we will be sharing the slides on the CDOC listserv. Right now, we're working on getting the website all tuned up so we can have all of our information on our website. Yeah, like I said, they'll be on the listserv probably next week sometime. Okay. So yeah, you can look for them.
I will show some of these slides to my students next fall. So this would be great.
Yeah,
great.
I tried to put almost everything I said during the webinar in the comments and below each slide. So even without the narrative, the slide should make sense.
Yes, and thank you for noting that. Dr. Anderson, we will, with the slides that are sent out, there are notes included.
Yes.
So, and that was another thing that our speakers took the time to do. So
Yeah, it'll be coming out as a PDF.
Would it be
And,
possible to get them as someplace, get them as slides? Because I will have a Zoom conference, a Zoom lecture next fall on GI cancer, and so it would be easier if they were actually sent also by as PowerPoint presentation.
Great. So Lisa, I'll send them to you. I'll share a file with you. They're too big to send by email. So
Okay,
they have to go into our G Suite.
all right, thanks.
all right, do we have any other questions before we close the call today? All right, well, I want to remind everyone, there is a link for our evaluation. So if I can ask everyone to please copy that link in your browser and complete that evaluation for us, that would be great. And I also want to, again, thank everyone who joined, and especially to our 3 speakers who provided all of this wonderful information and took the time to put together this presentation. So thank you so much, everyone, and have a great afternoon.
All right, thank you all. We appreciate
Thank you.
your help. All right.
Thank you.